Now we are able to see.
Okay. So going to the topic, this is regarding the surgical management of perihilar cholangiocarcinomas per se. Um, my so hilar cholangiocarcinomas are
Oh,
the
Ankit,
reason for
you
selecting this topic
muted
is
Rajesh
one is
also, I think.
during our MBBS days,
No, sir, he's
cholangiocarcinomas
audible,
are
sir.
considered as a tumor more of a palliative intent. Hello, sir. Pardon? Sorry, I'm not able to hear anybody.
You are audible, sir.
Sir, can I share?
It's running, sir. It's showing, sir.
Sir, am I audible? Sorry, there is a. Am I
Yes, sir, you
audible,
are
sir?
audible, sir. Yes, sir, you are audible, sir.
Is it the problem from my end or? Yeah. So this hilar cholangiocarcinomas, even though they are considered as a very relative slow going tumors, because of their proximity to. So I could see a lot of echoes. I could hear a lot of echoes. So because of the proximity to major inflow structures, even a small tumor of 1 or 2 centimeter will end up in having a major resection because of the vascular element. That's where this is considered as one of the most technically difficult tumors to resect. Surgical option is the only option in getting curative treatment of these tumors. And there is no big response to radiotherapy or chemotherapy for these tumors. That's where the surgeon's role play very important in uh, getting understanding the anatomy as well as getting R0 resection. So this is to give a brief introduction of how this tumor location is. So this is a different case where the bile duct alone has been resected, where a dilated bile duct was there, it has been resected. So just to give you a brief introduction of how this tumor location is. So this is a area of where the arterial anatomy, like the bifurcation of the proper hepatic artery to right hepatic artery, and the bile duct goes like this. So the right hepatic artery is in always close proximity to the common hepatic duct. That is number one important point. Second is if you see the bile duct, if it is here, the left hepatic artery is well away from the main duct or the primary tumor site. So that is a important anatomical point, say telling that left hepatic artery is rarely involved. And if you see the portal vein bifurcation, still it is very much low down compared to the bile duct biliary confluence. And if you see the anteroposterior view about the liver hilum, the hepatic duct is always superior compared to your left hepatic artery and the portal vein. This distribution is used in getting resection and going the resecting the biliary confluence as high as possible. Another thing about this hilar cholangios is because it involves the hilum, liver hilum, the caudate duct is involved. It's dilated, and one differential of, for example, a close differential to a hilar cholangiocarcinoma is gallbladder cancers, and any patient having a caudate duct dilatation, it implies more in favor of a hilar, just for the fact that it's involving the Okay. So, hilar cholangiocarcinomas, I got the slide. Uh, it has been defined. Yeah, you're able to hear me, sir.
Yes, sir, you're audible, sir.
Yeah, sorry for the inconvenience. So, hilar cholangiocarcinomas has been currently defined as a tumor arising in the perihalum area, which is defined by the right extent is where the right posterior duct is originated, and the left extent is where the umbilical portion of the left portal vein, right of the umbilical portion of the left. So, this area is considered as the tumor location for a perihilar cholangiocarcinoma. This has been described by Sibata. So, this perihilar cholangiocarcinomas um, compare, like, apart from the conventional types, what we have seen, there are other perihilar variants like intrahepatic cholangiocarcinomas where the mass is very close to the hilum. And that has been also included in perihilar cholangiocarcinomas where you can see the mass forming intrahepatic cholangiocarcinomas close to the hilum, where they define that if it is within this area as described above, it should be treated as a perihilar cholangiocarcinomas, whereas if an intrahepatic cholangio with a mass forming type is outside the umbilical portion of the left portal vein or on the right side, it is outside the right posterior duct, then it should be as an intrahepatic cholangios because the treatment option for both these things are the same. So there has been a lot of staging, that is classification, I would say, for perihilar cholangiocarcinomas. The first and foremost is the commonly used one is the Bismuth. This tells more about the longitudinal extent of the tumor. However, it doesn't give any information for the surgical resectability of these tumors. So there has been over the years there has been a lot of classification that has been put forth, and the importance of understanding the remnant liver volume, the hepatic artery involvement, portal vein involvement has been considered, and they are also included in the staging. And currently, the most common that has been followed in the West is the Bloomgard T staging, as well as the TNM current 8th edition, the TNM staging. The one important thing about the Western staging system is they consider contralateral hepatic artery or portal vein or a contralateral lobar atrophy as a unresectability. I would say that before going to the slide, I would say that unresectability can be determined only if there is a non-reconstructible portal vein or a hepatic artery. It should be labeled as non-reconstructible. It may be too high at this point of time. For students, it is better to go ahead with the current TNM staging and the Bloomberg staging. This slide is to highlight that what in the West they take Bloomberg T staging is considered as unresectable tumors because of the advanced stage and the contralateral vessel involvement. Whereas the same set of group in the Japanese, in the Nagoya University, they have a 30% 5-year survival. This is the, they have a good number of patients actually. Out of 268, 440, out of 445 patients, 268 is resected, quite a high resectable rate, and they have a good 5-year survival. So this is to say the importance of being aggressive in these tumors rather than considering them upfront as non-resectable and going for palliative. So in the imaging wise, perihilar cholangiocarcinomas are usually a long segmental strictures with irregular wall thickening with delayed enhancement. And to understand the resectability, it is important to have one is a radial and the longitudinal extent, the vascular invasion. The most important, I would say, is to understand the variant anatomy of these bile ducts, especially of these chordates, because chordate is something which you have to be aware of to suture the duct properly. Before most of the times, chordate is removed, but the duct going to the chordate has to be sutured properly. And the future liver remnant and the presence or absence of distant metastasis. CT is the best, no doubt, because it gives you more for the with the dilatation biliary systems are well visualized. You understand the arterial and the portal anatomy better. MRI and MRCPs are not as good as your CT scan because of the resolution. Basically, in a CT scan, we do about a 0.625 mm thickness, which is quite good enough to understand the vascular involvement. Whereas MRI, MRCP, the disadvantage is if there is a stone, for example, in front of the stricture, that might not assess you to help you to assess the longitudinal extent. And MRI doesn't have as good a spatial resolution. Other thing is MRI diffusion restriction can help you in understanding the lymph nodal status and any liver lesion which can mimic differentiated from the cholangicular abscess. PET scan, it has a role, but it's not as good compared to understanding the CTM. So this is a picture showing that how the gross biliary dilatation, you can see the atrophy of the left lobe because of the involvement of the portal vein. And this is the enhancement pattern of the cholangiocarcinomas. Lymph nodal enlargement in the cholangios are usually very false. A lot of false positives are there because, in fact, we have seen large lymph nodes in the hilum in a patient who undergone a pre-operative biliary drainage, and then we have found that those lesions are reactive rather than metastatic. So we have to be very cautious in deferring any patient for resection because of the large lymph nodal lesion. So this is the common vascular involvement showing here that this is a type 3B tumor where the left portal vein origin is involved. And on the right side, it's an arterial involvement of the right hepatic artery just below the duct. And right hepatic artery, as I said earlier, is one of the very common involvement because of anatomical location. What is more important is to understand this course of the artery to the portal vein, especially in cases like left trisectionectomy. This picture is important in a left trisectomy where left trisect is where you resect up to the left hepatectomy along with the anterior sectionectomy. So you need to preserve the right posterior hepatic artery. So in this image, you can see the right hepatic artery, or right posterior hepatic artery, is coursing over the portal vein, which is important to preserve because these cores are very prone for injuries when you do a left trisectomy. So it is important to understand the course. The common pathological variants of these tumors are moss-forming nodular variant. Periductal infiltrating is one important tumor where you need to understand the longitudinal extent, where frozen section of the margin becomes important. There is another, I would say, not milder, but relatively easier resections are the papillary type of hilar cholangiocarcinomas. Now they call it as the infraductal papillary neoplasm of the bile duct. These are important to identify because they are pre-invasive. Few of them are pre-invasive, and they have a very good resectability and a good prognosis. Another important thing about these lesions are there is a field change in the bile duct, so you need to have a proper follow-up of them, even after your 5 years of usual 5 years of surveillance. So the close differential is, as I said, IPNB, and the other is IgG4 cholangiopathy. So this is a classical IPNB where there is a ductal gross disproportionate ductal dilation because of the mucin secretion, and the papillary form where the bile duct lumen is filled with the papillary lesions and then stretch the bile duct. So as I told you, it's an excellent prognosis with resection. IgG4 is other one which almost mimic hilar cholangiocarcinomas, but the differential point here is I'll show you a picture here. You can see this is a IgG4 where the lumen is preserved, and you can see it's a circumferential thickening. That is one characteristic point, and it is multiple. They can have skip lesions both in the hilum and the intrapancreatic. Intrapancreatic is a bit classical for IgG4, along with there is no the mucosal surface of the bile duct is well maintained, and there is a uniform enhancement, which helps in differentiating IgG4. IgG4 cholangiopathy, it's not uncommon to see them with vessel involvement, especially even infra. But in the histopath, it's usually not an invasive component. So it's not uncommon to see a vascular involvement in IgG4. Still, that needs to be taken as a differential. So coming to the management of Perhilar cholangiocarcinomas. So as I said, bile duct resections alone was given an initial option, more of a palliative intent in earlier days. But over the years, it's the imaging, the surgical technique, the expertise, understanding the anatomical details, and good microvascular techniques that has helped in achieving R0 resections. And more, the role of liver transplant has come in a few selected group of these patients having a very good survival, almost up to 50%. What has been quoted in the literature is the Nagoya University results, because they are the one who pushed R0 resections to the maximum extent, and how they prepare the patient and how they bring a very good survival of these patients. The major thing that has helped them in achieving this is, one is assessing the remnant volume by ICG, portal vein embolization whenever it's required. They moved from PTBD to ENBD, and they have the thing about preoperative and postoperative symbiotic treatment. So I'll go into the details. So this is the results where they have combined the portal vein and arterial resections along with pancreatidectomy whenever required to achieve a R0 resection. So this picture is a very recent one where they have compiled the type of resections they have over the years they have done. As you can see, the very minimal violent resection or accidental laparotomy. They have gone in for an aggressive resection, and you can see right trisect, the proportion is increased, whereas same as the left hemi and left trisect. So aggressive resections definitely helps. Just to say what the West were doing, this is, even though it's an old comparison, Nagoya and Leahy clinic. So their caudate resection rates are very minimal, 8%, and the negative margin is very difficult to get it. And if you see the 5-year survival, it's grossly different. So surgical management of these patients definitely helps. As I told you, caudate resection is very important. How do you prepare them? So the definite indications for a preoperative biliary drainage is when obviously they have a cholangitis. Cholangitis in any form, even though there is a very gross remnant, if you're doing a resection and then even though 50%, 60% resection, in a patient with cholangitis, if you do a resection, the chance of them having a post-op liver failure is quite high. I've seen them patients succumbing within a day or two. So cholangitis has to be, you have to undergo a preoperative biliary drainage. And there is a plan for a neoadjuvant treatment. And whenever a portal vein embolization is being planned, you go ahead with a preoperative biliary drainage. So doing a drainage just for the raised bilirubin, there has been a lot of controversy regarding that. But we follow that when you're doing a right hepatectomy, where the left volume is less, we always try to get the bilirubin less than 2 to 3. So the advantages of preoperative biliary drainage, all described, it's decrease the renal and the bleeding complication. The disadvantage is procedure related and increasing the infectious complication. Whether to do bilateral or unilateral, it depends on, whenever you have to do only unilateral, it's the future liver remnant that has to be drained. And if you have a type 4 lesion where you don't know which hepatectomy you're going to do it, we always prefer to do it on the left. We understand that left side, it's not a bigger volume than the right side. The problem is left side, the chance of all the ducts draining with a single PTBD is high, whereas in the right anterior and posterior usually are separated, and you have to do multiple PTBDs in order if you want to do it on the right. So that need to be kept in mind. So this one paper said that preoperative biliary drainage may not be required, but however, it has been the current practice is whenever it's a patient is undergoing major hepatectomy, it is usually preceded with biliary drainage. And in the East, it's a routine drainage, and ENBD is the most common type that is used. We use PTBD. We felt that there is an advantage of doing a PTBD compared to an ENBD. The reason is nowadays we are using the PTBD track for putting in independent tube and using it for a post-op brachytherapy, where we find that having the tube is good. So remnant liver volume. This is a lesion where I would say that hilar cholangiocarcinoma is one where because it is involving close to the confluence of the portal vein. Naturally, there can be a portal vein embolization that is happening that helps actually. If not, if the liver remnant is, I would say, less than 40% in a compromised liver, it is definitely preferable to do a portal vein embolization and take it from there. So the concept of routine portal vein embolization is not accepted. There's no evidence to support that. And the portal vein embolization, the technique also is important. So as to make sure that you get the desired hypertrophy. Coil embolization along with gel actually helps in getting adequate hypertrophy. The other thing about portal vein embolization is it also gives you an assessment of how the remnant liver, the growth of the remnant liver. If it is hypertrophying, it's a good liver to understand the liver function test. ALPS is not advised in perihilar, principally for the because it's a dilated ductal system. You do a transection, the chances of bile leaks are high. So ALPS is usually not recommended. So going to the surgical options, perihilar cholangiocarcinomas, the early lesions, bismuth type 1 and type 2, where there's no obvious vascular involvement. There has been a discussion whether you do a parenchymal preserving liver resection or a major hepatectomies in these early lesions. What has been found that is, even though it's early lesions, there is quite a good amount of desmoplastic reaction and a perihilar invasion, perineural invasion. So it is definitely, even though these lesions are early, it is important to have an aggressive resection. And what was recommended is, if it is a nodular or infiltrating type, and the right hepatectomy is essential for the same factors I mentioned earlier. And if it is a papillary lesion, we can take an option without hepatectomy. So going to the locally advanced, where the vascular resections are common. Portal vein invasion is the most common, and less than 10% have a hepatic artery invasion. So surgeons are moved from doing a vascular resection as a one-off case to even almost doing a routine portal vein resection, just for the fact of the anatomical proximity. And Professor Peter Nagas, he does a routine portal vein embolization, and he found that the 5 years will significantly increased to 65%. The Nagoya University group, they actually do a segmental hepatic artery dissection whenever and they have found recently that it doesn't influence morbidity or mortality. Like there is R0, it increases the R0 resection rate and doesn't increase the morbidity or mortality much as thought of. This is a classical type A hilar cholangiocarcinomas. Where you can see the right portal structures are involved, and in fact, it is being pulled. And this is a tumor this is a portal vein resection of these of this hepatic. This is the CT scan of the same patient showing an atrophy lobe as a totally spontaneous portal vein embolization, portal vein block, and this thing happens. So there is no need of a portal vein embolization. You already have a hypertrophied left lobe. This is the intra picture where because these are slow growing, it gives time for this atrophy and hypertrophy to happen. Is there a difference between a right-sided hepatectomies and the left-sided hepatectomies? Yeah. The difference is the anatomical point to be noted is right-sided hepatectomies the left hepatic artery is always arid. That is number one. So it is good to preserve the left lobe. Left portal vein has a long extrahepatic length, and it is easy to resect and reconnect. Because once you mobilize the portal vein, like in a Whipple, there is a redundant portal vein. You can easily like 1 to 2 centimeters also if you can resect and then anastomose without difficulty. And left hepatic duct has a longer length, so you have a good oncological clearance. So if you are planning for a right hepatectomy, it is absolutely easy in terms of your vascular resection, not much of vascular resection, or if at all it is only just a portal vein resection that will be required. But the only problem in a right hepatectomy is the remnant liver volume is going to be low. So that is where the whole thing has shifted more like preserving, doing this is scenarios where you have an option of both right and left, where now they are shifting more to doing a left hepatectomy and then doing all the vascular reconstructions so as to have a good remnant volume. So this is exactly as I told you. It's a right extended hepatectomies, even though they are technically easier, oncologically better, very less bile leak, the artery is away, and it is usually a single anastomosis. All these things are quite advantageous in an oncological, from an oncological point of view. But the remnant volume is going to be low. In an extended left, it is going to be a difficult resection. Hepatic artery resections are quite high, quite difficult, but your remnant liver is going to be good. So it is based on the type of hyalocollectomy you do the resection. This is the same point. We described, Professor Rella described that technique of Rex Reese's approach where he went for a right side hepatectomy instead of going to the hilum, he went almost to the umbilical portion of the left portal vein and did an anastomosis there to have a high radical, like radial margin. So I can show you one video. This is the technique. This is a type of cholangiocarcinoma where the portal vein, main portal vein, as well as the right and the left were involved. These are usually considered as palliative, whereas like yeah. So here the right hepatic artery. So it's a right hepatic type 4 lesion where you have a right hepatic artery. This is the main portal vein being looped. So this is a caudate vein that has been the main bile duct. Process section of the bile duct has to be done both from the distal and the proximal. So once you are done, get the portal vein and the artery looped. So here the internal jugular vein is being harvested. I think you are able to see the video now.
Video is, yeah. But it is slowly moving.
Second. You're able to see the videos, no?
Yeah, we
No,
could.
sir.
Sir, I think there is a problem with my internet, I think so. So I would skip the.
It was moving slowly. Your video was moving slowly.
Yeah, but it stopped. 1 second, sir. Because for me, it is like, it's very. It's okay. So I'll go to the next one. You're able to see my slides, sir? Yeah. So basically, as I told you, type 3B lesions are the one which where the remnant white is quite.
Sir, you have to share your screen again, sir.
Yeah.
So yes, type 3, now it's visible, sir.
Yeah. No, type 3B lesions are the one where you have a good remnant volume. So that is a big advantage in a type 3 lesion. But because your right hepatic artery, the remnant artery is the right hepatic artery, because it's going next to the hilum, you most of the time you land up in doing a portal vein and an artery. The difficulty of doing a portal vein resection in right hepatectomy, in left hepatectomy is it depends on how the bifurcation of your anterior and posterior portal vein is. So you have to have a control of the right anterior and the posterior portal vein before doing a reconstruction of the before doing the reconstruction of doing a portal vein reconstruction. And usually there is a stretch always on the portal vein ensemble, so you usually keep mobs at the back of the like right lobe and then get it closer to get the reconstruction done. But it is easy compared to a like even though it is difficult compared to a left-sided portal vein resection anastomosis, but it is doable. So this is the paper I mentioned earlier regarding the portal vein and the hepatic artery, which is simultaneously resected. Obviously, this is usually done in a left-sided hepectomies, and they found that the prognosis, the survival is good, not as good as your portal vein, but this good. That is, it is one of the options that need to be with a mortality of 2%. So it should not be discarded. These patients should not be denied a surgical option. So, as I said, patient selection is very important. This is, I think, this is the type 3B. Yeah, it's the same problem here. There is a sorry for the internet. I think there is a problem with the internet. So this is a type 3 tumor where you have an artery as well as a portal vein reconstructed. This is a follow-up post-op picture. One other thing regarding in these tumors is hepatopancreatic duodenectomies. When do you do that? Actually, people think that only in advanced cases these patients require hepatopancreatic. We have seen even in early lesions like bismuth type 1 and type 2, where there is a no longitudinal extent, and then you don't get a distal nective margin, and then you will end up in doing hepatopancreatic duodenectomies. It was initially described in gallbladder cancer, but there are selective situations where you might have to do a hepatopancreatic duodenectomy, especially when your patient selection is good, they land up in having good survival. So even though they have achieved R0 resections in these patients, because the high perineural invasion and the severe desmoplastic lesion that they have, there are instances where like the recurrences are still a problem in the post-op follow-up, and in fact, it is 50% at the end of 5 years recurrence. So these patients has to be followed up for at least 5 years. In few studies, they have extended it almost up to 10 years, and there is no good adjuvant therapies in managing these patients in the post-op. Recently, as I said earlier, we have introduced the brachytherapy along with the post-op chemo in trying to get recurrence, like have a lesser recurrence. We have to wait for the results. So to end, this is the Nagoya University's distribution of the resections based on your hepatectomy alone, with artery, without artery. And they found that still they have a very good 5 year and 7 years survival, which is very impressive. And the surgical option is definitely a treatment option in managing cholangiocarcinoma. Ourselves, we do a lot of vascular resections, almost 50% of them. It's a refer bias, I would say. And then we get all the complex cases, and then 18% of them land up in arterial resection. And as we over the years, we have found that doing leftectomy with a vascular section is easier compared to doing a right, where the post-op it is very difficult. If a small insult can tilt the balance, and then they can have a post-op liver failure. So transplant, I'm not going to the detail of transplant, but I'll just tell you that transplant is also an option in few selected patients. One is primary sclerosing cholangitis with cholangiocarcinoma. That is a different variant where you do a transplant both for the ESC and the cholangio when it is early. Second is unresectable tumors less than 3 centimeters. I would say the current criteria is when there is a pathologically confirmed cholangiocarcinoma, the tumor size is less than 3 centimeters without any evidence of distant metastasis. You have a biopsy confirmation and there is no lymph nodal involvement. They are put through a protocol where radiation, brachytherapy, chemotherapy are given stepwise, and the patient are taken in for surgery to make sure explore laparotomy or now staging laparoscopy is done to make sure there is no spread. Once they go through this protocol and then they are transplanted, surprisingly they had a 5-year survival of 82%. And there is a recent literature that is published with a good number of patients having almost up to 5 years survival of 70%, 70 to 75% minimum. That says good about this liver transplant in a selected group of cholangiocarcinomas. I want to end that by saying that it is definitely a good option, but however, there are a lot of vascular complications in these transplant patients who have undergone this neoadjuvant therapy, especially portal vein and artery because of the radiation. And the results are not as good as we think. So overall, when you see a liver transplant for a perihilar cholangiocarcinoma, the figure that says 5 years survival of 64% versus 18% for a resection. However, I would conclude by saying that this transplant option is only for 14% of the overall patients that actually come for a transplant. It's not an option for all the patients. So still resection has a role to play in these patients. Thank you. I'm really sorry for the video that I think there is a problem with the internet connectivity. So I'm really sorry for the video. Thank you so much.
Thank you very much, Rajesh. Before I open it for question answer session or discussing the chart, questions in the chat box, let me welcome Professor Ananth Krishnan and some of the senior people like Dr. GVSN Prasad, Professor Krishnamurthy, and our Dr. Shaktivel Harikrishnan, and some of them I can't recognize this one. So if I miss somebody, oh, I'm very sorry for that. So let's start the discussion with Professor Ananth Krishnan asking some questions, I think, or some comments from Professor Ananth Krishnan.
Thanks, Vishnu. Nice talk, Rajesh. Learned a lot from it. I am no expert to ask you questions, so I leave the questions to others, but a very nice comprehensive talk.
Thank you so much, sir. Big words for me. Thank you so much.
Great job as always.
Thank you.
So I think Dr. Shaktivel Harikrishnan has recently returned from King's College. He may have some questions. So before I ask him, let me tell you our experience with the hilar cholangiocarcinoma in our department. So far we have, I think we have treated nearly more than 60 patients of hilar cholangiocarcinoma in our department, but only 1/3 are resectable. We have done a resection in 20 or so odd number of patients, but with a higher mortality rate of 30%, right? And we have tried doing portal vein resection in just 2 patients with a mortality. So we were not successful, but we're trying to improve every time. So currently there are 2 patients who are readmitted. So one of them patient, since the surgery extended late night, so we couldn't get the resection margin, and the post-operative resection margin came positive. And because of this, he received a radiotherapy, and he developed a radiation enteritis, and we had to resect a small bowel and make a stoma. Currently, he is in our ward. And there's a second patient who had a leak from the hepaticojejunostomy. We had to he underwent again an extended right hepatectomy, and then the stoma, this hepaticojejunostomy had leaked, but we redid it. He went home, but now he has come back after a year with a with a strictured hepaticojejunostomy. So I would like to ask you the question, supposing if there is a negative positive margin, what will you do in the post-operative status, in the post-operative this thing, and is there a role for a redo hepaticojejunostomy in these patients who have got a small bile duct anastomose to the jejunum? These are the practical questions. Apart from that, we would like to discuss later, right? So
Yeah. So regarding the margin positivity during resection, these lesions are periductal infiltrating types usually when we go as much as margin. In fact, last almost like 35 hilar cholangios I was only doing it, and then Professor Ayla comes and says, if I have 4-5 ducts on the remnant side to reconstruct, that means that I have gone as much as possible. So you can't go in much more than those. In fact, the maximum number of ducts I've done is almost 7 on the right side. So we can't go into the liver as much as, so you have to leave it to the post-op adjuvant therapy to take, because the risk of going in, like as I said, when you ask me whether you can do a left trisectionectomy compared to a left hepatectomy, I would say that left hepatectomy with going more and more into the hilum and then having multiple ducts is better to do with a good volume of liver rather than doing a left trisection, taking the anterior sector off. The advantage here is you still have the amount of liver that you left behind is still good for the patient to withstand any stress, let's say a leak or any vascular complication. So there is a reserve in the patient, and to avoid the post-operative liver failure. In case if the margin is still positive, that's where we have this the PTPD, which in turn helps us track for the brachytherapy. That's a maximum that can be done. Beyond that, I can't, because you can't risk a patient life by going in for on a margin positive, and then you are not able to reconstruct any duct and causing more bile leaks. That's a problem. So I would say that if you have achieved as much as resection as possible, a good number of bile ducts, and then still post margin, adjuvant is the only option. Going into the liver and then doing a very difficult hepatic jejunostomy you have to weigh the risk, I would say.
As per the literature, I think there is no difference between whether we choose a right-sided resection or a left-sided resection for a type 4 hilar cholangiocarcinoma. Though your paper, which I have seen, suggests left side is better than the right side because the functional liver remnant on the right side is more and the liver function will be better preserved. That's the conclusion written by your paper, which I have seen. But if you look into the meta-analysis, there is no significant difference.
Yeah, this preference towards left hepatectomy is basically because of the transplant experience and vascular resections, artery and portal vein. We never think twice to do an artery. If you have a reconstructible artery, distally and proximally or looped it, we just resect it and then anastomose. There is no second thought or whether to go ahead and whether arterial dissections will be a problem. Only when you add a hepatopancreatic duodenectomy, we try to avoid an arterial dissection because any leak that time will jeopardize, it can cause this new anastomosis to erode, and then so that is the only instance where we don't try to do it. Another thing about margin positivity is for example, when you are doing a left hepatectomy, we try to take most of the segment 5 as well. The reason is when you take the segment 5, the hilum, you are able to give more margin. If in case it comes as positive, you have an advantage of going deep into the liver and giving margin. So even leftectomy, you have to take a bit of like the gallbladder fossa, you try to take it out so that even if you want to extend your margin to go into the liver, better to have a transection line so that at the end, in your reconstructing, there is no liver hanging over the bile duct and then having difficulty in the reconstruction. I don't know whether I told correctly, but it is important to have, for example, if you have a worry about giving a margin positive, your transection plane has to be in such a way that you are able to revise the duct margin. You have to mobilize the vessels, everything, and then you should be able to give a duct margin for go into the liver to get a margin negative.
Okay, some of the other controversies in the literature is doing a what do you call the without dissecting the tumor, arm block resection of the tumor, suggested by Peter and one of your from paper from your institution, Rex Reses approach also advocates the same, but there is no evidence to prove that arm block resection of the tumor along with the portal vein, hepatic artery, it doesn't improve the survival. What do you say?
I would say in type 4 tumors where the main portal vein as well as the main portal vein is involved, there is no point in doing a hilar dissection, where definitely there is an advantage in doing a Rex Reses approach. The problem is
what is advocated by your Rex Reses approach. I have seen some of the discussion part and all. It says that you, without looking into whether the portal vein, even the Peter Nyes says whether the portal vein is involved or not, no touch technique, just resect it and reconstruct.
Yeah.
That's not a valid approach. You have to see whether portal vein is really involved, then you resect it. So that's what the majority people advise. Only Peter Nyes group and your Rex Reses approach advocates whether it's involved or not, cut it and anastomose. Or your comments in that paper says like that.
Yeah. Sir, Rex Reses approach is usually advocated only in selected group of patients where the portal vein is involved in the CT. It is not advocated when you don't have a portal vein narrowing. Definitely no. This is more and so applicable in cases where there is a main portal vein involvement as well. So doing a dissection there is just trying to find out whether it is involved. It doesn't make any sense. Our worry about this Rex Reses approach is again the remnant liver volume that is left behind is small. So that's where we started in cases where it is type 4 and it is more of a right portal structures involved where you have to do a right hepatectomy, Rex Reses definitely has an advantage. There is no doubt. There is no choice of doing a left hepatectomy here. But whenever there is a chance of doing a left hepatectomy, we have gone ahead doing a left hepatectomy and then doing an artery and portal vein resection. That's what I'm trying to say. Doing a routine portal vein resection, we also don't advocate. The CT should show some narrowing, or intraoperatively you find that it is when we, for example, left portal vein origin is involved and it is close to the portal vein confluence, we don't hesitate to resect it out, the confluence, because even though you are able to take the left hepatic vein off from the confluence, still it can be new tumor margin positivity. So we actually, even after taking the lesion, hepatectomy done, after taking the tumor out, then we have still gone on doing the portal vein resection reconstruction because it is straightforward.
Why take the internal jugular vein rather than taking a left renal vein, which would have been better?
Internal jugular vein has an advantage of one is you have a length, the caliber. We found that to be useful compared to a left renal vein, and most of these patients are a bit old, not because it is a personal choice, sir, but we find that internal jugular vein is safer.
No, I was only worried because you have to come to the neck, make one more incision rather than remain in the abdomen.
But you are not disturbing any of the system because in an old age, like these patients are advanced age, and then you disturb your renal circulation. I'm not saying that the left renal vein has any implication, but still, jugular vein, taking a jugular vein has no problems. We have no problems.
Okay, let me ask some questions which we have come across, which we have faced in our ward. Are you doing this fish method for diagnosing the hilar cholangiocarcinoma? Because we are unable to get this test done.
We do brush it. So we do brush cytology. As I said earlier, one of the close differential is IgG4, where one patient where we went ahead and then resecting it because we thought that vascular involvement is there. And then the final biopsy came as IgG4 cholangiopathy. I would say that is one-off case. Still, because the resections still helped, like our results with resections are better, we still go ahead and do it.
Okay. The second is we rely on the FAPI PET to rule out a metastasis. How much you rely on this FAPI PET? Is it necessary in all the patients? What's your experience?
PET scan, it's a type of PET scan, is it?
Yeah. Type of PET scan, which is available in our institute.
Sorry, sir. I don't have that.
Let's first ask the other people to ask questions. I think we'll start with our these things. Shaktivel, who has recently returned. After that, the Shanmugam Saurajit can ask, I think.
Good morning, sir. Thank you, VP sir, for starting this initiative of Saturday morning class. It's a wonderful thing. It's a good learning opportunity for all the young and budding surgeons to learn from all the senior people, senior experienced surgeons, especially from JIPMA. And Rajesh, sir, thank you for, as usual, for a wonderful talk and sharing your high volume experience. My question is, when I was in Stanley, I had a few experience with managing hilar cholangiocarcinoma because many cases gets referred to Professor Jaswant sir, and there most of the, as you said, hilar cholangiocarcinoma locally advanced and end up being unresectable, and most of the patients we end up doing only a PT of both the right and left lobes just for a palliative symptomatic control to treat the cholangitis. My question is, in cases which ended up being resected, sir used to optimize the FLR by doing a portal vein embolization, and he prefers right extended hepatectomy, and where he takes a resection line to the left of the umbilical fissure to get good margins. My question is whether in King's I found that we have been doing extended liver venous deprivation also, including hepatic vein embolization. So are we doing that for hilar cholangiocarcinoma in your center, sir?
Yeah. One of the methods to improve the remnant liver volume is, apart from portal vein embolization, you do the same lobe, you do a hepatic vein like embolization as well, deprivation, that's called as, which has shown that there is another 10-15% increase in the liver volume, which is definitely a very good technique. But most of the hilar cholangiocarcinomas that we have seen, they have already had a portal vein narrowing, and then they had a hypertrophy atrophy complex. So the purpose is already served, and then we do a preoperative biliary drainage, and then went ahead with the section. Where there is a portal vein embolization, we have not done. To our experience, we have not done any venous deprivation along with the portal vein embolization. As I said, we were more towards the left hepatectomies and then doing vascular resection, and then we are happy with the remnant liver volume. Only when your remnant liver volume is, let's say, it's less than 40 or 30% in a compromised liver, then you definitely go for a portal vein embolization. And as you say, hepatic venous deprivation actually helps.
Yes, sir. Thank you, sir. And the other thing is, apart from, you said the differential diagnosis being very commonly IgG4 cholangiopathy. And when I was in Stanley, sir also used to think about tubercular stricture in young patients presenting with the hilar stricture. And we have seen one patient with the central hilar stricture with both the right and left, and we ended up doing a right extended, and the post-op specimen was the right tubercular stricture. with even tuberculous hilar lymph nodes also showed caseous lymph node involvement.
Yeah, this is one where I said looking into the caudate duct dilatation is one thing that helps in bringing into the differential. Like if there is no caudate dilatation, you have a right and the left ducts uh, dilated, and then you don't have a caudate duct enlargement there. You really think about the diagnosis of perihilar, because perihilar is one where it will cause a caudate duct, significant caudate duct dilatation. It's not a usual upstream dilatation, it will cause a significant. So that is one finding which helped us in picking up more of these lesions. And if that is not there, then we actually bring the differentials into the discussion and then do further evaluation to avoid a major resection in these patients.
Yes. Thank you, sir. Thank you, sir, again for sharing your experience. Thank you.
Chat box by Vishal says, written, it's a great pleasure to attend your presentation and a very good initiative to have such meeting. I have one doubt. When we are not able to differentiate a stricture in the right and left hepatic duct as malignant or benign, with usual radiological investigation, what will be your plan of management when patient is having jaundice? The question in the chat box.
Unilateral involvement of the bile duct, and then you are not able to prove a malignancy or not. The further evaluation will be based on whether the patient is not amenable for a surgical management. Because if it is a surgically amenable lesion, like the patient is able to undergo without much of morbidity or the mortality, if you are not increasing the risk, then it's straightforward. Because the reason why I'm saying this is, even if you get a negative result by doing a brush cytology, or let's say even US guided FNEC, still if it comes as negative, you still have a worry. Unless you take the lesion completely out, you will not be 100% sure. So when the patient is amenable for a surgical management, I would say better to do a resection, right or left, depending on where the lesion is, even though it is not, if you still have a doubt about a malignancy. For example, you do a brush cytology and it comes as TB or IgG or something. That's fine. It's a specific diagnosis. You are happy with that, and then you go out of the treatment. But if you don't able to come up with the diagnosis, better to do the surgical resection.
There's one more question in the chat. This question in the chat box by Dr. Sauradeep says, sir, do you do preoperative tissue diagnosis? If yes, what would be the indication and how do you do it? We get quite a number of young patients with hilar stricture with a doubt in diagnosis, being whether it's a sclerosing cholangitis or IgG4 cholangitis, and I've had problems. Second question is, do you do frozen section from bile duct margin for all cases? And if not, a post-op biopsy shows R1 resection, what are the treatment options? The third one, in case where you did a portal vein resection, reconstruction, how have been your experience with a short-term and long-term outcome in hilar CC, hilar cholangio? The question is in the chat box. You can have a look at it and answer.
So, coming to the first question, preoperative tissue diagnosis, as I said, if it's a clear-cut malignant stricture, like you have a vascular involvement along with grossly dilated bile duct, and these are very bilirubin up to like more than 10, 15 or so, then it's a straightforward diagnosis. The possibility of having a benign in these settings is very unlikely. Whereas the same situation where you have a tight hilar stricture and the bilirubin, let's say it's around 5, and young patient, you don't have a vascular involvement. And one finding in the CT which helps you is when the mucosal part of even though there is a narrowing, when the mucosal part of the bile duct is not showing shouldering or enhancement, or it is only a focal enhancement, not a circumferential. These are the things. If it is a circumferential enhancement rather than a focal, like in cholangiocarcinoma, These are the times where we think twice whether it's a malignancy or we are dealing with something else. Where we investigate with spyglass, we do a fish, we try to investigate further in understanding whether we are dealing with something else. But you have a patient with 15, 20 billi with a vascular involvement where we don't try to have a tissue diagnosis. That's number one. Frozen section is always done both for the distal as well as the proximal. So because it is more to, one is if you are surgically able to revise it, that's fine. And it is about giving an adjuvant. For example, you have done a major resection and your distal bile duct margin is positive. You can't do a hepatopancreatic duodenectomy at that point. We actually you can postpone because this patient has to come out from your major resection, liver resection. Then you can even plan your surgery like hepatopancreatectomy 2 to 3 months later and then do it. For example, this is typically done in a patient who had a PSC with a cholangiocarcinoma where the distal margin was positive for a transplant. So we have to do a Whipple's post-op. The biopsy came in the post-op, and then we have to go out and do a Whipple in the within 6 weeks of the transplant. We have to go and do a Whipple's, where it was like the bile duct, distal bile duct margin was positive in the primary transplant setting. So he's a doctor and he's well now. What I'm saying is, it is based on frozen section is very, very important. There is no second thought about that. The third question is, in case where we do a portal vein resection, how have been your experience with the short term and long term? Perfectly fine. In fact, doing a portal vein resection helps you to give a good margin. I would say that because you mobilize it better, and then your duct margin also you can once you mobilize the proximal, the distal well for a reconstruction, because you have to put a clamp. So obviously you will be able to give a good bile duct margins. So portal vein resections, as the complications like narrowing, portal vein narrowing, post-op, all these things are less unless until it's a recurrence.
Dr. Shanmugam, do you have any question?
No, sir. Thank you.
Anybody else would like to ask question? Please, you can speak directly and ask him. Okay, I don't think there are any further questions. Thank you very much, Rajesh. And
thank you so much, sir.
I thank all the senior people, including Professor Anand Krishnan, who have took their time to join this meeting. I'm really grateful to all of them. Thank you, Rajesh, once again.
Thank you so much for this opportunity, sir. I'm looking forward to attend all the talks. Thank you, sir. Thank you.
Next week also is your talk, same time.
Sir, people will get bored. I would come a bit later.
Since it has been
It's up to you, sir. It's up to you. If nobody is coming forward, I'm happy to.
You can finish it up, I think. It's like
sure.
You are teaching us and we are learning from you.
Sir, I learned everything from there. Thank you so much, sir. Thank you, sir.
I think we'll leave the meeting, Alan.
Yeah.
Thank you all.
Thank you, sir.
Recording stop.